Thank you. Good evening, everyone. It's my pleasure to present the first webinar organised by the Royal College to supplement training that's obviously going to be lost during the coronavirus problem. My lecture is on the chest X-ray interpretation in an ITU setting. This is not exclusively about ITU, but any situation where the patient is very sick, such as the ER or emergency department and in high dependency units. So I work in Liverpool University Hospital's NHS Foundation Trust, and I've been based at Aintree for the last 23 years. I also contribute to Radiology Masters, which is a website with live screencasts, videos on various radiology topics. So please look this up and try and get some more education from videos. My learning objective is to demonstrate common and clinically important pathologies seen on the chest X-ray in ITU, HDU, and in resus settings. You probably all know this, but medical education does save lives in slow motion. And sometimes, as in intensive care or emergency radiology, it can save lives pretty quickly. Don't forget the basic tenets of radiology. Structures of a different radiographic density that lie adjacent to each other can be easily seen separately. In other words, one structure casts a silhouette against the other. When the air spaces opacify, the silhouette is lost between the lung and the adjacent structures, i.e. the heart and the vessels, but it is created between consolidated lung and air-filled bronchi, the so-called bronchogram. This is a nice example of an air bronchogram in a patient with right upper lobe pneumonia. Why am I showing the image of the World Trade Center? Well, in 1986, as a medical student, I was walking down Manhattan and I took this photograph on a summer's day. If you like, the blood vessel is represented by the skyscraper, and the mist that descends over the skyscraper obscures the blood vessel. And this is the basis of consolidation. When you get to the situation where you've got dense consolidation but a patent bronchus, you can then see the bronchogram. Here is the interface of the horizontal fissure, thereby diagnosing a right upper lobe pneumonia. Okay, so what's the relevance of this to ITU? Most patients on ITU, although not all of them, will have an endotracheal tube. And it's often asked quite a lot of clinicians and of radiologists, where is the ideal place for the ET tube to be? So ideally, it should be 4 centimeters from the carina in the mid-trachea, but it is allowed to be anywhere between 2.5 and 5 centimeters. Don't forget that during flexion and extension of the neck of the patient, the ET tube can migrate upwards and damage the vocal cords, and migrate downwards and intubate one of the main bronchi. This is a patient who has ARDS and a pneumomediastinum, and you can clearly see that the ET tube is in the correct position in the mid-trachea. If you can't see the carina, look for the T4-5 interspace, and that is approximately where the carina will be located. The cuff balloon should never exceed the tracheal diameter, and the reason for that is that we want to avoid necrosis of the tracheal mucosa leading to stenosis. So this patient has the endotracheal tube situated 4.5 centimeters from the carina, and this is ideal. This patient has an ET tube which is too low. You can clearly see that the carina is bridged by the right endotracheal tube, which goes down the right main bronchus, and the patient needs that retracting pretty quickly, otherwise they will develop lobar collapse. This is a schematic diagram just showing where the ET tube is with relation with the carina. But once again, if you can't see the carina, aim for the T4-5 interspace. This is a young patient, 4 years of age, who has a endotracheal tube placed in the right main bronchus, presumably because it was too large, and the patient attended an adult hospital. This has resulted in consolidation and collapse of the right upper lobe, and there is early collapse of the left lower lobe. Note the bilateral VP shunts. So again, this shows that the ET tube is beyond the carina in the right main bronchus. Yet another example, this time it's in the right main bronchus, the right lung looks normal, but the left lung is starting to retain secretions and becoming denser as it starts to collapse. Here is the fulminant collapse with an endotracheal tube deep down in the right main bronchus, and this has led to collapse. Shortly after the tube was retracted, the chest X-ray looks a lot better. This is a patient who is in resus and is desaturating. You can see that the endotracheal tube looks as if it's in the right position. Fortunately, in this particular case, the film is so rotated that it now demonstrates that the endotracheal tube is in the esophagus and not in the trachea. So there's esophageal intubation. You can also see gaseous distension of the stomach because of the esophageal intubation. So this needs to be corrected pretty quickly, otherwise the patient is in real trouble. This patient has had a variceal hemorrhage, and as part of the treatment for variceal hemorrhage, they've had a Seng-Stark and Blakemore tube inserted. The balloon has been inflated and traction has been applied to the tube to press on the varices. Everything looks good with that respect, but the endotracheal tube is intubating the right main bronchus, leading to left lung collapse. So this is an issue that needs sorting out pretty quickly. Patients may go on to have a tracheostomy if there's a long need for ventilatory support. So after about 2 weeks, to avoid tracheal stenosis, tracheostomies are fashioned. Tracheostomies are not usually affected by patient movement, and the tip of the tracheostomy tube should be positioned ideally between 1/3 and 1/2 from the stoma to the carina, and should not be any more than 2/3 of the diameter of the trachea. What about central lines? Well, there's 3 different types. The one most often used is the subclavian line. This can lead to pneumothorax, and care should be taken. A PICC line, peripherally inserted central venous catheter, often is inserted in the arm, and that can end up with its tip being in one of the central veins, and then the internal jugular line. Now, whatever method is used, the tip of the central venous catheter should be in the SVC, just proximal to the right atrium. You should avoid parking the catheter more proximally to avoid the valves near the brachiocephalic veins, so that you can get an accurate CVP estimation. The catheter tip is approximately in the 1/3 of the SVC, will be liable to thrombose, and this is of the order of about 10 to 15 times more likely than if the tip of the catheter was more distally placed beyond the proximal 1/3. If it's too distal, however, in other words, in the right atrium, this may produce ventricular arrhythmias and cardiac perforation. And cardiac perforation will lead to pericardial tamponade. So, how do you know whether the subclavian vein has been cannulated properly? The line should project beneath or behind the clavicle, But if it's cephalad to the clavicle, consider that an arterial puncture has occurred or that there's been extravascular placement. Always look for a pneumothorax in subclavian line insertion, and don't forget to look for mediastinal widening in case you've traumatized the mediastinum on the way in. Right-sided lines, because they represent a shorter route from the skin to the SVC, are more likely to be intracardiac, and this can lead to arrhythmias, cardiac perforation, and pericardial tamponade. Don't forget normal variants. This is a left-sided SVC. I've done a diagram on the right-hand side to demonstrate the course of the left-sided SVC. So there are two lines here, both of which are taking a turn to the left, meaning that there's no right-sided SVC. The left-sided SVC then goes behind the heart, behind the left atrium, and inserts into the right atrium via the coronary sinus. This is another patient who has ARDS. They have a left-sided pneumothorax, and you can see just barely, I've had to draw this again with red. You can see that the line that's coming from the left is going down into the left SVC. Left SVC usually isn't a problem unless, of course, you are unaware of it, and this then causes some doubt as to where the line is. If you are familiar with this anomaly, you will have no trouble with it. Don't forget, if you instill intravenous fluids down this line, it could potentially cause arrhythmias because the left SVC goes near the conducting tissue of the heart. Here's yet another example of a left-sided SVC, this time cannulated using a PICC line, and it goes preferentially down the left side. This is the venogram to confirm the presence of the left-sided SVC. You can see that the coronary sinus is that much bigger in patients with left-sided SVCs in order for the venous drainage to collect blood from the coronary veins, but also from the left SVC into that coronary sinus. So this is a movie which I'm unable to play. Not to worry, I'll move on to the next slide. This is a patient who's had a right-sided internal jugular attempt, but instead there's been a right arterial puncture. And you can guess that there's been a problem because of the course of the catheter is slightly unusual. It's not what you would expect for somebody with a right internal jugular venous line. This patient has had a right internal jugular line. Note that they've got bilateral alveolar pulmonary edema. And soon after the line goes in, you can see that there's a right apical cap. This is a triangular density adjacent to the superior sulcus. And in fact, it's not in the lung, but it's in the extrapleural space. And what's happened here is that as the line has gone in, it's caused some arterial haemorrhage, which has collected in the extrapleural space. That's the space which is superficial to the parietal pleura. I've drawn a diagram to describe what this extrapleural cap actually is. I'm unable to move the mouse, so ignore the arrow. You can see on the X-ray on the left-hand side that this young chap who's been run over by a car has got a widened mediastinum. A widened mediastinum in this context is always very serious because of the history of trauma. But in other patients, it can sometimes be a non-specific finding. But the thing that makes this very specific are two radiological signs. One, you can't see the aortic knuckle because there's mediastinal hematoma up against the aorta. And also, blood in the mediastinum has tracked over the superior sulcus, superficial to the parietal pleura, and this is called the extrapleural cap or apical cap. And just in the last example where the line has gone in, it's the same mechanism. It's usually an arterial bleed in the extrapleural space. Note also the fractured clavicle on the left side and the contusion in the lung. Correct NG tube placement. This is as important on ITU as it is on the wards, and it's a potential never event if patients get fed via the NG tube when it's in the wrong place. So it's vitally important that all doctors, especially radiologists, can understand how you can verify the course of the nasogastric tube. It should really bisect the carina, and then it turns to the left to enter the stomach at the gastroesophageal junction. And this is the correct course. But I've seen so many times nasogastric tubes being in the wrong place, and I'll show you some examples. This is a patient who has bilateral alveolar bat's wing pulmonary edema, very classical. The ET tube is in the correct position, just above the carina, within 2.5 centimeters. Within 5 centimeters and not nearer than 2.5 centimeters. The right internal jugular line looks okay, but you can see that the nasogastric tube has intubated the right main bronchus and is now in the right lower lobe bronchus. This patient needs the NG tube removing immediately wherever they are. And if this patient happens to be in X-ray, we would remove it there and then. There is another example where the patient has got a nasogastric tube which has intubated the right main bronchus, now into the right lower lobe bronchus, and it's gone so far down into the right costophrenic angle that it is likely to have caused visceral pleural damage. So the key here is that the radiologist should alert the clinician that once this tube gets removed, there's a very high risk that the patient will get a pneumothorax because of the breach of the visceral pleura. And in fact, that's what's happened. The tube gets removed and the patient gets a pneumothorax. So I think it's very important that the radiologist does alert this particular problem to the clinician. There is another example where the nasogastric tube looks as if it might be in a dilated esophagus. If the patient was slightly rotated, you could argue that maybe it is in the esophagus, but I don't like the fact that the tube doesn't deviate to the left as it bisects the carina. If we look at another film, quite often you get edge enhanced films to allow you to see the tube a bit more clearly. And when the tube comes out, the patient gets a pneumothorax because, of course, the tube is in the medial basal bronchus in the right lower lobe. And it's gone so far that it's damaged the visceral pleura. So on retracting the tube, the patient gets a pneumothorax. Which brings me on to the next topic, pneumothorax. Here is a patient who has a pneumothorax. You can see inspiration and expiration films. You can see a line indicating the lung edge on both the inspiration and expiration films. The pneumothorax looks slightly bigger on the expiration film, but actually the reason why expiration films are usually done is that the increased density of the collapsing lung against the low density of the pneumothorax is allowing a better contrast resolution. If you can't see the lung edge, look for absence of blood vessels, and that's a secondary sign of pneumothorax. Here is an obvious pneumothorax with an obvious lung edge and surgical emphysema. I couldn't find any particularly good diagrams in the book, so I drew these myself. In a supine patient, you do get evidence of a deep costophrenic sulcus. So on the scanogram on the left-hand side, you can see that the right costophrenic angle is much deeper than it is on the left. And this is because the patient has a supine pneumothorax. Now, when the patient lies down flat, don't forget that any gas that collects in the pleural space is more likely to do so at the bases, because the bases are less dependent than anywhere else in the thorax. So you need to look very carefully at the CP angles and for the lucency over the liver for evidence of an anterior basal pneumothorax. So here is the close-up of that patient. The right CP angle is much lower than it is on the left-hand side. And this is the CT done on this patient. You can see that the CP angle is much lower on the right. The patient's had a tube positioned. That tube is in the horizontal fissure. What constitutes a tension pneumothorax? Well, I think that this is a clinical diagnosis, and the mechanism is that you get such an increase in the pleural pressure that it now exceeds the atmospheric pressure and also exceeds the intra-abdominal pressure. So as well as mediastinal shift being one of the signs, note that you can see this with any pneumothorax, not just a tension pneumothorax. You need to look for something that marks this as a tension pneumothorax. And this is flattening and eversion of the diaphragm. So I was always taught at medical school, don't do an X-ray in this situation, recognize the problem clinically. And I think that holds true today. But quite often we still get patients who have tension pneumothorax on X-ray and CT. So here is a tension pneumothorax. The patient has got contusion of the left lung. Note that this is a patient who is supine, and it's a ground glass appearance to the left hemithorax, because not only is there a tension pneumothorax, but there's a tension hemopneumothorax. When I was a senior registrar many years ago at the Royal Liverpool Hospital, I came in the middle of the night to do a CT scan on a patient who'd been run over. And during the scan, the anaesthetist was very worried about the patient. Before we'd done the CT scan, we did a scanogram, as we normally do. And you can see very clearly that there is depression of the diaphragm. Again, there's a ground glass appearance to the left hemithorax, because it's not just a pneumothorax, but it's a hemopneumothorax. And the depression of the diaphragm means it's under tension. And this was the first time in my career that I'd ever done this, but I put a green needle in the second intercostal space, mid-clavicular line, and this hissing note came out of the green needle. So it was a real baptism of fire for me when I was a senior reg on call. The green needle gave us a bit of time to put another chest drain in. And it just goes to show that even though the patient has got 2 chest drains in situ, the radiologist doesn't always know whether those drains are working. Maybe they are blocked, maybe somebody's clamped them. So always bear that in mind. This is one more recently, an ITU patient. They had had a right internal jugular line put in, and the radiographer was on their way up to do the check X-ray, and suddenly the patient went off. So there was an opportunity to do the X-ray, and you can see that the left hemidiaphragm is in the normal position. The right hemidiaphragm can't even be seen because the pneumothorax is under so much tension, it's pushing down the right hemidiaphragm. And again, this was treated in the usual way, firstly with a green needle cannula, then with a chest drain. Sometimes you can see tension pneumothoraces on CT, and the same principles apply. A scanogram is effectively a supine chest X-ray. And you can see on the sagittal image particularly, there is severe depression of the left hemidiaphragm with eversion. This was a tension pneumothorax in a patient with chest injury and contusions in the lung. Sometimes the patient is very sick, they've had an intercostal drain put in, but the drain doesn't work. This is a patient who's had many rib fractures, treated with internal fixation. They've had an intercostal drain, but it's never really been working. And that's because the drain is in the lung and not in the pleural space. Now, it's very good if you can pick this up on a chest x-ray, but sometimes you need a CT to work it out. And this particular patient had the drain inserted into the lung. You know it's in the lung and not in the fissure because you've got hemorrhage around the drain. This is a patient who was assaulted, and she had a rib fracture which caused an intercostal artery bleed. There was obviously a breach in the parietal pleura, and this resulted in a tension hemothorax. Now, whether it's a tension pneumothorax or a tension hemothorax, in both situations, the reason why these patients don't do very well is because you impede the venous return to the heart because of the massive increased intrathoracic pressure. This was the CT of the same patient. You can see the sentinel bleed and the hematoma that's residing in the dependent portion of the left hemithorax. But I hope you can also see that there is massive depression of the diaphragm because this hemothorax is under tension. And one of the worst things you can do in this situation is to stick an intercostal drain into the hemothorax before discussing it with a chest surgeon or an interventional radiologist to stop the intercostal bleed. Pneumomediastinum can be very subtle, as in this case. Patient presents with chest pain. There is a thin line adjacent to the left heart border, which is the mediastinal pleura being stripped away from the heart. And this is a pneumomediastinum. Perhaps the most important job of the radiologist is to alert the clinician to the fact that this might be due to an esophageal rupture, although there are other causes. So this time the movie works. This is a nice example of a pneumomediastinum. Note the portal venous gas and note the pneumoperitoneum. This was a young guy who had a perforation of the esophagus during endoscopy. And it just nicely shows the pneumomediastinum. I'll play that again if I can. So we've got nicely defined anatomy around the mediastinal structures, extending up into the neck, supraclavicular fossa, and there's also pneumoretroperitoneum. We can see some gas around the left kidney. This was a perforated esophagus during endoscopy. Here is pneumomediastinum in a patient who has ARDS. You can see the old-fashioned Swan-Ganz catheter, which is no longer used in ITU settings. Here is a pneumomediastinum, which strips the thymus off the left heart border. Note, you can also see the continuous diaphragm sign. So the diaphragm is continuous from right to left without being interrupted, because there's now gas between the diaphragm and the heart. You only see this in a pneumomediastinum. Also, look at the deep sulcus sign. The patient has got a pneumothorax in a supine position. Here's another example of the continuous diaphragm sign in ITU. So the patient has an ET tube in situ. They're on a ventilator, and the positive pressure ventilation causes barotrauma, which causes pneumomediastinum. Note also the surgical emphysema. Here's the CT of the same patient. They've also got some ground glass changes in the lung, which are due to generalized infiltration, probably as a prelude to ARDS. So this is the continuous diaphragm sign, very important. It looks a lot different to pneumopericardium. We can see here that the gas that surrounds the heart stops at the superior pericardial recess, and it does not give you the continuous diaphragm sign. Now, pneumopericardium is almost always caused by trauma, which it was in this case. Here's another example of pneumopericardium. This time, the patient has also got a pneumoperitoneum. Apologies for the spelling. And this was trauma associated. Okay, let's have a look at some pneumonia examples. This is right lower lobe consolidation. You can't see the right hemidiaphragm, but you can see the right heart border. This is a lobar pneumonia, and it's probably going to be due to something like pneumococcal pneumonia. Here is a patient who has a right upper lobe pneumonia with a bulging fissure. This was actually due to Legionella, and it's quite a common cause now of the bulging fissure sign. The books originally described this as pneumococcal or Klebsiella, but don't forget Legionella pneumonia, and it's worth mentioning that to the ITU doctors. This is a young male with a fever, turned out to be an atypical pneumonia, mycoplasma. Whenever you see something like this, always think, could this be atypical? If this was a little less confluent and more ground glass, obviously think about Pneumocystis, jiroveci pneumonia, what we used to call PCP in the past. But this was mycoplasma. Here is a patient with Pneumocystis, jiroveci pneumonia. There's a ground glass change in a perihilar distribution. Don't forget that all of these X-rays need to have clinical correlation. So it has to fit with the clinical picture in order to get the right diagnosis. This is a COVID-19 patient who has got peripheral consolidation in both lungs. Pulmonary edema. The most important slide I can show you is this one here. It describes the anatomy of the secondary pulmonary lobule. The bronchus and the pulmonary artery are always seen together, and they are in the center of that anatomical unit called the secondary pulmonary lobule. The pulmonary vein and the lymphatics run in the gaps between the lobules called the interlobular septa. And so when you get pulmonary venous hypertension, where you get fluid oozing out of the veins, as you do with interstitial pulmonary edema, you get septal lines. You get septal lines also with lymphatics, and if you have an obstruction of lymph flow back to the hilum, you get septal lines in lymphangitis. So here is a patient who has heart failure. They have curly B lines, and these are interstitial lines full of fluid that has been oozing out of the pulmonary veins. Note also that the patient has got an ET tube which is too low and needs to be retracted. This is a patient who has interstitial pulmonary edema. Here is another example. You can see nice curly B lines extending right up into the left midzone. This is due to heart failure. Eventually, the interstitial pulmonary edema leads on to bat's wing alveolar pulmonary edema. This is rather asymmetrical, but it's very perihilar in its distribution. The thing that demarcates pulmonary edema from ARDS is usually other features of pulmonary edema, such as upper lobe blood diversion, the perihilar central nature of the edema. The patient may be fluid overloaded or may have cardiac disease or an enlarged heart, and there may be associated pleural effusions. Whereas ARDS tends to be a bit more general in its distribution. Another example of bat's wing pulmonary edema. The clue that the patient may have a cardiac problem is that in spite of the AP nature of the film, the heart looks enlarged and also the pacemaker. This is a film you've seen earlier, just a nice example of bat's wing pulmonary edema, but the most important thing here is the NG tube in the wrong place. If you ever see a lamellar pleural effusion, this is virtually pathognomonic of heart failure. So this is fluid that gets trapped between the lung and the visceral pleura and is a very potent sign of heart failure. Don't forget, young people can get pulmonary edema, not necessarily because they've got cardiac disease, but because they may have a neurogenic insult, such as subarachnoid hemorrhage or head injury. So this patient had neurogenic pulmonary edema and the associated subarachnoid hemorrhage. This is quite a rare cause of pulmonary edema. I've only ever seen it a few times. Patient has a pneumothorax. This gets treated with an intercostal drain, and this is the film about 2 hours later. So it shows that the lung is not fully, but nearly fully reinflated, and the patient actually felt very well. 8 hours after the initial presentation, the patient then goes on to feel unwell, and you can see that there's re-expansion pulmonary edema. Now, the differential diagnosis might be that the drain has caused hemorrhage because it's in the lung, but that is not really a plausible diagnosis because the 3-hour film shows a good position of the tube when the patient was well. So this is re-expansion pulmonary edema. Pneumoperitoneum, we need to look below the diaphragm on ITU films just as much as we do on ordinary films in the department. And this is a clear and obvious case of pneumoperitoneum, leading, when you look at the abdominal film, to the detection of Wriggler's sign. Note also the triangle of gas which is projected over the right upper quadrant. So this is pneumoperitoneum. It can be more subtle, as we all know. Note that this patient has had a laparotomy, and this is just a trace of gas afterwards, but it can be very subtle. Now, because patients on ITU tend to be semi-erect or semi-supine, you don't always see the classical pneumoperitoneum in the position that's shown here. So here is a patient who has the so-called cupola sign, and this is the football sign, which is collecting not around the umbilicus, but underneath the center of the diaphragm. And here it is. It's called the cupola sign, named after an Italian church dome called a cupola. Okay, I'm going to move on to trauma, and then we're going to show some miscellaneous ITU films. Here is a patient who has sustained an aortic laceration. Now, as I mentioned earlier, widening of the mediastinum could be due to non-traumatic causes. Okay, so we need to look for other features that suggest the diagnosis. And the biggest clue that this patient's got an aortic injury is the fact that not only have they got a widened mediastinum, but the normal contour of the aorta has been lost because there's now hematoma right up against the aorta. Patient then goes and has a CT scan, and you can see that there's lots of mediastinal hematoma. Adjacent to the aortic knuckle, there's an aortic laceration, so-called pseudoaneurysm, and a good deal of mediastinal hematoma. So when you're looking at the chest X-ray, always look for the nice aortic contour. And if that is absent or displaced or distorted in the patient who has suffered trauma, always think about aortic laceration. A flail segment is where you get a fracture involving 2 or more ribs in 2 or more places. And this leads to a flail segment. And this is a cardiothoracic surgical emergency. Unless this patient gets this fixed, the ventilation to the right lung will be virtually non-existent and will lead to poor oxygenation and lead to infection. So these need to be treated pretty promptly. And most trauma centres now have a very low threshold for internal fixation of the ribs. I'm going to go back to this patient with a tension pneumothorax with depression of the diaphragm. And you can see that the diaphragm is depressed, it's everted, it's distorting the stomach bubble, and the CP angle is very low. So there's the deep sulcus sign, but there's also eversion of the diaphragm. And hopefully the video will play to demonstrate what I mean. You can see the eversion of the diaphragm, lots of contusion in the lungs, but most importantly, look how depressed and everted that diaphragm is. That was a tension pneumothorax on the CT scanner. This is one of my favourite films. It shows a patient who has had a major road traffic accident, and the widened mediastinum is because there's mediastinal hematoma, either due to a brachiocephalic trunk injury or an aortic laceration. It's reasonable to suppose that it might actually be a brachiocephalic trunk injury because the apical cap is on the right-hand side, not on the left. So that fits with everything sensible. There's also some increased density in the right hemithorax, and this could be contusion or hemothorax. But a lot of people who look at this film fail to realise that there's a neck injury. And you can see that there's quite a large gap between the C6 and C7 vertebrae. So this is because the patient's got a hyperextension facet lock injury. So always imagine that you're the clinician at the scene of the patient coming into resus, and try and look at the x-ray as if you're the clinician on the ground. And hopefully you won't omit important things like neck injury. So I'm going to finish with some miscellaneous cases which are of interest and importance. Don't forget, if you see a very large cardiac silhouette, which is unexpected, consider it could be a pericardial effusion. Now, this was not an ITU patient, but over the course of about 3 or 4 months, the cardiac silhouette changes, and that's because it's due to a pericardial effusion. But you can apply the same principle to an ITU situation, and always, always, always look at previous films. Foreign bodies, this is a patient who inhales a dental bridge. That probably will never end up on ITU, but it just serves as a reminder to think about inhaled foreign bodies. Here is a child with an inhaled foreign body causing hyperexpansion of the left hemithorax because the foreign body has led to air trapping. So the size of the foreign body is sufficiently large enough to allow air to be trapped during expiration, but sufficiently small enough to allow air around the foreign body in the first place during inspiration. This was a trauma patient who had all the trauma abnormalities reported very nicely on the film, but unfortunately the tooth that was in the lower trachea was missed on the original trauma. Anyway, the patient did very well from the trauma, and then they went on to have problems about 3 or 4 days later. And you can actually see that the tooth, which was in the trachea, has now migrated into the right lower lobe bronchus, leading to right lower lobe collapse. It's very difficult to see the tooth, even with retrospect. But if you look at the chest radiograph, you can see the tooth in the lower trachea on the original post-intubation film. I'm very grateful to Dr. Ghislaine Sayer for allowing me to use this case. If you look at the film on the left, the patient has a tracheostomy, and they've also got a density just above the tracheostomy. If you then look at the film on the right, that density has migrated into the left main bronchus. So the pharyngeal tooth has moved to cause harm in the left main bronchus. So always look at densities that you can't explain and try and give an explanation for it. It may be that the endotracheal intubation has been traumatic and the patient has lost a tooth, or maybe it's due to trauma, as in this case, where the patient has had a fractured mandible and some of the tooth fragments have been inhaled into the right lower lobe bronchus. So this patient has had a ruptured left hemidiaphragm. They injured themselves as a passenger in a car. They were on an orthopedic ward with a fractured femur. And 24 hours later, the chest x-ray now looks like this, and this is because although the diaphragm was injured at the time of the accident, it may take 24 hours for the intra-abdominal contents to migrate through the defect, in this case. This was a ruptured diaphragm that we originally missed on the first film. So the patient has got a hemothorax, it's a supine film. On the left-hand side, you've got increased density due to the hemothorax. The CT scan shows some perisplenic hemorrhage and some perihepatic hemorrhage, but everything else looks okay. Unfortunately, I can't move this mouse, which unfortunately is obscuring the important bit on this film. But anyway, day one, 24 hours later, the stomach migrates up into the chest. And if we then go and have a look at the CT on day two, we can see that there's a rupture of the left hemidiaphragm, as denoted by that yellow arrow. And unfortunately, this is a video that won't play. Oh, yes, it will. And you can see very carefully on the left side, the diaphragm is ruptured and the fat that's in the abdomen has migrated through the defect. So one of the ways of not missing a ruptured hemidiaphragm is to look very, very carefully on the coronal sections and make it part of your checklist to exclude the rupture. Okay, there are 4 steps to success when looking at chest x-rays in the high dependency ITU setting. You absolutely have to have the right clinical information to make the right diagnosis. You have to have a good understanding of anatomy so that you know where the pathology is. You need to understand the silhouette sign. And most importantly, if you find ITU films difficult, you'll find them much less difficult if you practice, practice, practice. I'd like to thank all my colleagues, registrars, consultants who work with me at Aintree and in the Mersey region. I'd like to thank Dr. Stephen Harden and his colleagues from the Royal College of Radiologists for being so supportive in this venture. And a special thanks to my colleagues, Dr. Dan Fasher and Dr. Radhika Prasad, who with me run Radiology Masters. Dr. Jane Young and Dr. Peter D'Souza from the London School of Radiology, who were also inspirational, and in particular Dr. Jane Young for coming up with this concept of teaching people online whilst we're having this coronavirus problem. Do visit Radiology Masters for more education and videos. And just a quick mention to the next webinar, which is coming up on the 31st of March and another one on the 2nd of April. So Dan Fasher is going to talk about anatomy and common pathologies on MR of the knee, and Dr. Radhika Prasad will talk about common radiology on-call scenarios. So both of those topics are significantly important for trainees at ST1 to ST3 level, but also to any consultants who are watching. So thank you very much for your attention. Okay, so I'm going to read any questions and try and answer them verbally rather than writing in the chat box. Oh, here we go. I've found lots of questions now. Yeah, so is aortic transection a spectrum of aortic laceration? Yes, it is. So what happens is when you have a decelerating injury, you get an intimal tear which goes into the media, and that intimomedial tear is visible radiologically, usually on CT. If the laceration extends beyond the adventitia, that usually leads to exsanguination and the patient dies. But if the laceration extends up to the adventitia without involving it, it causes a pseudoaneurysm. And the pseudoaneurysm is what you see at presentation during the CT scan. So it usually occurs distal to the ligamentum arteriosum, and that represents the anatomical part of the aorta that is a junction between the mobile arch and the not so mobile descending thoracic aorta. So it's all part of the same spectrum. If we're just looking at trauma on the chest x-ray, the things to look out for are widening of the mediastinum, loss of the normal contour of the aortic knuckle. If the patient has got a nasogastric tube in situ, that nasogastric tube tends to be deviated to the right-hand side. And a sign which is very difficult to pick up is depression of the left main bronchus. But effectively, all of those signs are historical, really, because most patients will get a CT scan. But you've got to remember that in a major civilian disaster, or this present coronavirus crisis, we may not have ready access to CT scanning. And so it's beholden on all of us to be able to pick up all these signs on a chest x-ray. Okay, I'm just, let's have a look. No question, thanks for the webinar. Okay, no problem. Could you remind me of the tracheostomy measurements again? Okay, so tracheostomy, it should really be halfway down the trachea between the stoma site and the carina. You could have it a third of the way down or half the way down, but no more and no less. The other measurement with the tracheostomy is the diameter of the tracheostomy should be no more than 2/3 the diameter of the trachea. Somebody's asking a question about left-sided SVC. Where would the line position be deemed appropriate? That's a very, very good question. I would say halfway between the origin of the SVC and the coronary sinus. So you want to park that catheter in the largest diameter of the SVC, and that would be about right. With all left-sided SVCs, there is a theoretical risk of causing arrhythmias because it runs very close to the conducting bundle. Could somebody kindly show the lamellar effusion again? Okay, I'll try and do that. Let me just see. I'm going to show you the lamellar effusion. Hopefully you can all see this. What happens is interlobular septa become thickened because they've got lots of fluid because of pulmonary venous tension. And then what happens is, if you imagine that the visceral pleura is welded to the lung, there's a potential space between the lung and the visceral pleura. And in that potential space, what happens is the septa move into that potential space, causing a lamellar effusion. So it's not really in the pleural space, it's in the space between the visceral pleura and the lung. And it's a very, very important pathognomonic sign of heart failure. Somebody's asking me, what's the distance for the ET tube again? Ideally, it should be 4 centimeters away from the carina, but you are allowed for it to be no nearer than 2.5 centimeters and no further than 5 centimeters. So if it's any nearer than 2.5 centimeters, there's a danger that you can intubate either of the main bronchi during flexion of the patient's neck. If it's more than 5 centimeters away from the carina, there is a risk that when you inflate the cuff, you can damage the vocal cords and the tube can come out. So 4 centimeters is the magic number for the ET tube. Why is portal venous gas a feature of esophageal perforation? That's a very, very good question. I've often thought about that myself, because in this particular patient, this did happen. They got portal venous gas because what happens is the pressure inside the endoscopy procedure that causes the esophageal perforation it allows gas to track into interstitial compartments. Hence, you can get retroperitoneal gas, you can get mediastinal gas. And the gas that's present in these compartments has to be absorbed, and it gets absorbed by the mesenteric veins if it's below the diaphragm. And I think that's why you get portal venous gas. So this particular patient was actually quite well. So it's a benign, or a relatively benign cause of portal venous gas. Any more questions? Could I explain the anatomy of the secondary pulmonary lobule and how curly lines are formed? Okay, so if you look at this slide here, you can see that the patient has secondary pulmonary lobules all lined up like paving stones. Here's the interlobular septum, here is the bronchus, here's the pulmonary artery, and running in the septum, which is the gap between the lobules, we've got the pulmonary veins and the lymphatics. So if the pulmonary venous pressure is very high, such as left ventricular failure, fluid that resides in that vein is going to ooze out into the space between the lobules, causing the septal thickening. And the septal thickening is actually linear. So you see it in profile on the chest x-ray as curly B lines. And that's a very good sign of interstitial pulmonary edema. But so too, if it was unilateral and you had a right hilar mass lesion, you may get curly B lines just on the right and not on the left. And that's because the lymphatics also run in that space. I think they are all the questions. So thank you very much for your attention. Please keep safe during this particularly difficult time. And thank you for being an NHS worker. And please support all your colleagues. Thank you very much indeed.